had a gross decentration of IUL. Vision of the patient was 6 by 60. Patient was taken up for redialing of IUL, but the IUL decentered again. So what I planned here was tucking the same IUL in the sclera with the help of a fibrin glue. You can see here the lens is subluxated down, it's out of the pupillary center, and patient is complaining of haze. So what I do, I put an AC maintainer, what has been told by Dr. Naresh, ki you have to have an AC maintainer or an vitreous infusion cannula. Two flaps are created nasally and temporally. A sclerotomy is made with the help of a 22 gauge needle. Then this lens is brought into the center with the help of a Sinskey hook so that it does not dislocate into the vitreous cavity. Now I introduce a 23 gauge end opening forceps from the nasal sclerotomy, and from this paracentesis I introduce another 23 gauge forceps. And I hold the haptics in the center. Once the haptic is held, and I gradually do an handshake technique and hold this haptic at the tip of the three-piece lens. And once the lens is held at the tip, it is externalized from the nasal sclerotomy. Once the haptic is externalized from the nasal sclerotomy, and again a 23 gauge forceps is put from the temporal sclerotomy, that is 1.5 millimeters behind the limbus. And again with the handshake technique, I hold the haptic right in the center and do an handshake technique. You can see very clearly here that I am holding the tip of the haptics, because if you don't hold the tip of the haptics while externalizing it, you can bend the haptics or you can break the haptics. Once both the haptics are internalized, I do just an anterior vitrectomy, clear all this debris here, and then a tunnel is created with a 26 gauge needle, and this haptic is internalized into this tunnel, and glue is placed. While placing the glue, you should ensure that your infusion cannula should be off and this area should be dry, because if you don't dry the area, then the glue will get washed off, because it takes around 20 seconds to both thrombin and fibrinogen to mix together and get adhered. So this is the end result. If we see 1 week post-operatively, well-centered lens with 6/6 vision. Now there is another patient here underwent complicated cataract surgery with sector iridectomy. The surgeon has placed an AC IUL, and this AC IUL has also gone down. The other eye vision is good. So now what choice we have? We cannot put an AC IUL because we know that AC IUL has gone down, and the only choice left is do a scleral fixated lens. If we see the fundus examination, OCT shows intraretinal cystic edema with an SRF, suggestive of cystoid macular edema. So what we did, we placed an AC maintainer, we created a flap nasally and temporally, sclerotomy was created with 22 gauge needle, and we used the sclerotomy to do a vitreous surgery. The vitreous is cleared from the IUL, and it, with the help of a 23 gauge forceps, we bring the IUL right into the pupillary plane. With the handshake technique, a scleral tunnel is created. With the handshake technique, the haptic is held, and this haptic is externalized from the scleral tunnel. Now the second, once the haptic is externalized, the second forceps is used in the scaffold, where the lens is gradually slid out of the scleral tunnel. You don't have to pull the lens out, you have to gently rotate the lens to bring it out, because if you pull the lens out, you can also damage the corneal endothelium. Once the ACIOL is removed, then a three-piece lens is placed. This is my preferred technique. I hold the haptic with the 23 gauge forceps and handshake technique. Then you can exactly hold the tip of the haptic, and this haptic is externalized from the nasal sclerotomy. Once this haptic is externalized, the second haptic is also externalized from the temporal sclerotomy. With the help of a 26 gauge needle, a tunnel is created, and then this haptic is internalized into this tunnel. The flaps are glued, and if you see the post-operative result, you can see a well-centered IOL. An amazing thing what you see here is that the CME has resolved, and 1 month patient has improved to 618. This also gives an information that with sutured scleral fixated IOL, we had a lot of pseudo-phacodonosis. But with glued scleral fixated IOL, the lens is rock stable, there's no pseudo-phacodonosis. So what happens that CME decreases in glued scleral fixated IOL as compared to the sutured scleral fixated IOL, where the pseudo-phacodonosis is more and the incidence of CME in sutured scleral fixated IOL is somewhere around 33%. This another patient of 12 years old male had a perforating injury which was sutured locally. The vision was hand movements, had a corneal scar, peripheral anterior synechia, partially absorbed cataract with occlusio pupilli. We didn't have a view of the fundus, so we did an ultrasound to see what is the status of the posterior segment, and the posterior segment was within normal limit. We placed an AC maintainer in this patient, and we used a 23 gauge cannula, and I have created a rent here in this tight pupil, and through this rent I am trying to do the vitrectomy. I'll come out of this and I try to bisect this peripheral anterior synechia, but at this stage I find this is too hard to be cut with a 20 gauge cutter. So I created corneoscleral tunnel, and with a 1/2 forceps I just section the peripheral anterior synechia. Along with that I do a sphincterotomy, that is supranasally, infranasally and superiorly. By doing this procedure, what I do is I enlarge the pupil so that I can see the posterior segment. Once the pupil is enlarged, I do a vitrectomy and clear all this debris or the absorbed cataract from this patient. Now I need to know how is the posterior segment, but with so much of trauma, you expect some kind of problems in the posterior segment. So I put in light pipe and examine the posterior segment. You can see a near normal posterior segment. So next I proceed to go in for an glued scleral fixated IOL. I create a flap nasally and temporally. With the help of an injector, the lens is injected. The tip of the haptic is caught and externalized. Once both the haptics are externalized, a scleral tunnel is made with the help of a 26 gauge needle, and these haptics are internalized into this. So these are the post-operative pictures. You can see a well-centered IOL. Nothing was possible with other I66 vision. Nothing was possible except glued IOL in this patient or a sutured scleral fix. And this was a young child of somewhere around 10 years. So another sutured IOL we couldn't put. So glued IOL was the only option in these patients. And this patient luckily improved to 618. Here is a case of pseudophakic bullous keratopathy with ACIOL with non-dilating pupil. You can see here we have created a flaps nasally and temporally. I have placed an infusion cannula infratemporally. With the help of a 22 gauge needle, a sclerotomy is created, and then vitrectomy is done. The lens, the ACIOL is removed. You can see the haptic of the ACIOL is stuck into the angle. It's pretty difficult situation. Many times you have to cut this haptic, because if you forcefully remove this haptic, you can land up with iodolisis or anterior segment bleed. Since the pupil was small, so I used a pupil expander, that is Maliguin ring, to dilate the pupil. Maliguin, the size of the Maliguin ring what I am using is 6.5. The pupil is dilated. After that, a 3-piece lens is introduced into the eye. The tip of the lens of the IOL is held with the 23 gauge forceps and externalized. Similarly, the other haptic is also internalized and externalized from the nasal sclerotomy. Once both the haptics are externalized, the malignant ring is removed, and then we have created a donor tissue, the lenticule for DSEC, which is introduced through the scleral tunnel through a Boussin's glide. This is how you dislodge the malignant ring and remove this malignant ring. Once the ring is removed, a lenticule is prepared and is pulled inside the eye with the help of a 23 gauge forceps. Once the DSEC lenticule is introduced into the eye, air bubble is placed, the lenticule is centered, and the flaps are glued. You can see day 1 post-op results. The lenticule is well absorbed, a well-centered glued IUL. This is 1 week post-operative and 3 weeks post-operative. This patient improved to 618. AS-OCT shows a well-attached lenticule. This is another patient of aniridia. Why I wanted to put this photograph here. You can see actual anatomy of the lens in the sulcus. The lens is placed in the sulcus, and you can see the orientation of the haptics, how well these haptics are there. Coming to the complications, although Dr. Athia has described almost all the complication, one complication which I felt had in my series of patient of 300 was this choroidal disinsertion. This is a patient who has underwent VR surgery, had undergone silicone oil removal, and after that whole in-back complex dislocated into the posterior segment. It was a 3-piece IUL, so I plan to fix the same IUL in the glue the same IUL. So AC maintainer is placed. This is a chandelier light, and we have made the flaps nasally and temporally. Now you see, while introducing this 22 gauge needle, you can see whole of the iris root here. This is important here. Whole of the iris root is coming into the center. I realize this, so I measure the distance. Maybe I am pretty anterior, so I go for a posterior route. But again, you can see there is a disinsertion here. I recognize this disinsertion, so what I did, I abandoned this region and I created 2 flaps, infratemporally and supratemporally, so that I don't create further disinsertion. I examine this area also, and nothing I can find I can intervene. You can see whole of the in-back lens dislocated into the vitreous cavity. The lens is held and brought into the pupillary plane, and with a handshake technique I clear the capsule from the haptics and then externalize this haptics. Once this haptic is externalized, the capsule on the other haptic is also cleared with the help of a vitreous cutter. And once this capsule is cleared, I hold the haptic of the lens and externalize it. At this stage, I am not able to externalize this haptic and I lose this haptics. And when I try to enter again, you can see here, whole of the iris ciliary body complex is coming out, and actually you can see ciliary processes here. So at this stage, I realized I have created a major complication. I have created a cleft between the anterior chamber and the sclera, and my patient will land up with a severe hypotony post-operatively. I abandon this procedure. I explant the lens and fill the eye with silicone oil. So post-operatively, You can see an anterior near normal posterior segment. First day the tension was 2 millimeters. It remained 2 to 3 millimeters for next 15 days, and it became normal in 1 month. Suddenly, after 3 months, patient came with a raised intraocular pressure of 40, and at that stage, I realized that there is an attachment of ciliary body to the sclera, and then I can remove the silicone oil. So next step, what I did, I removed the silicone oil, put an ACIOL. Patient is maintaining 6/12 vision. Another problem, what one of the doctors in the audience were telling us, ki haptic exposure. If you have an haptic exposure, then what you do, you create a conjunctival flap, lift up the old flap and create another tunnel. And you internalize this haptic into this tunnel. And then you can suture the conjunctiva. So to conclude, glued scleral fixated IOL has opened new paradigms in treating and rehabilitating young patients who would have been left aphakic with no useful vision. I'd like to thank Dr. Gabor and Dr. Amar, the mentor of glued scleral fixated IOL, for giving this wonderful procedure to us. Thank you very much for your kind attention.